Good morning, student. Today we will discuss about the arterial blood gas analysis. It's one of the supportive diagnostic tool, especially for the patient with respiratory diseases and different metabolic conditions. So how to interpret the arterial blood gas analysis? Before going to the topic proper, why we do the ABG? In our day-to-day clinical practice, we take the arterial blood by the radial artery. We take the sample in a heparinized syringe. So it helps in diagnosing the different respiratory conditions like COPD or pneumonia, as well as it also helps in diagnosing a condition like diabetes ketoacidosis. So it gives us an idea regarding the acid-base status of our body. It gives us an idea regarding the partial pressure of oxygen and the carbon dioxide. It gives us an idea regarding the alveolar arterial oxygen gradient. So basically ABG helps us in identifying the acid-base problems and the oxygen status in our body. So when you get the sample of the ABG report, so first of all, before interpreting the ABG report, the number one is we have to know our patient. So as we have already discussed in the lecture of the X-ray and the ECG, we have to know our patient. So what is their history? What is the examination? Like, let's suppose there is 65-year-old male with shortness of breath for 2 years and cough for 1 year. So on examination there is expiratory wheeze is there. Then we suspect that patient might be suffering from the COPD, and accordingly we have to analyze the ABG. In another scenario, if a patient is diabetic with high blood sugar, suddenly present with acute shortness of breath, then we have to think about the DKA, diabetes ketoacidosis. So we have to know the history, and it's better if you know the examination finding of our patient before analyzing the ABG report. So then second thing is we have to validate whether this ABG report is appropriate or not, because there can occur so many technical error while taking out the sample of the arterial blood. There can be different handling error and the machine error. So we have to validate whether this ABG report is accurate or not. So for the validation, we have the modified Henderson equation, which says that the 24 is the product of the hydrogen ion multiplied by bicarbonate ion divided by partial pressure of CO2. So in the ABG report, we can easily get the bicarbonate concentration, we can easily get the partial pressure of carbon dioxide, but it's difficult to get the hydrogen ion concentration. So what's the formula for getting the hydrogen ion concentration in shortcuts? For getting the hydrogen ion concentration, as plus is, I am going to tell you a very simple formula, okay? It's just 80 minus, okay, then 2-digit after decimal of pH. This is the simplistic idea to get the hydrogen ion concentration. Let's suppose pH of your patient is 7.35. Then what is the hydrogen ion concentration? Is the 80 minus 2 digit after decimal of pH, means this is the decimal, after means 3 and 5, so 35. So 80 minus 35 is near about 45. So we can get the hydrogen ion concentration by applying this formula, that is 80 minus 2 digit after decimal of pH. That if pH is 7.35, then 2 digit is 35. If pH is 7.40, then 2 digit is 40. So if you subtract that number from the 80, then you will get the approximate hydrogen ion concentration in the body. Then if it is 45 here, now let us look at one example. If someone has the pH of 7.4, okay, 40, and hydrogen ion, bicarbonate ion is 25 millimole, and PuCO2 is 40. It's not like we easily get this type of ABG in normal individual. Now, is this ABG report valid or not? So 24 equals to H plus is 80 minus 40 is 40, bicarbonate is 24 divided by PCO2 is 40, so 40 clock, and is 24 equals to 24. So this is valid. So this, I can say that this ABG report is valid. If it is valid, then we can go ahead and we have to interpret the ABG. Okay, so this is how you check the validity of the ABG. Okay, then we have validated. So identify the primary problem. If you see the ABG, then we have to identify what is the primary problem in the ABG. So for that, what you have to do to identify the primary problem, what you have to do, you have to look at the pH, you have to look at the level of SCO3, you have to look at the level of PaCO2. Okay, so first of all we look at the pH. If pH is, the normal pH is 7.35 to 7.45, some say 7.4, some say 7.4, but we have a range 7.5. It's the normal pH. If it is normal pH, so if you get the pH value less than 7.35 here in this range, if it is less than 7.5, like 7.3 like here, then this is the acidemia or acidemia. The pH is low. If pH is high, then it is the if pH is high, then it is called the alkalemia. So decrease in pH less than the normal limit is acidemia, increase in pH more than the normal limit is alkalemia. But because of what there is acidemia or alkalemia, we have to know. So if someone present with the ABG report of 7.3, you can say there is acidemia. But there are two conditions that can decrease the pH less than 7.35. One is, as we have already know, as pH is directly proportional to the HCO3 and inversely proportional to the partial pressure of oxygen as per the Anderson and Hasselbalch reaction. So increase in bicarbonate will increase your pH, decrease in bicarbonate will decrease your pH. Increase in carbon dioxide will decrease your pH. Decrease in partial pressure of carbon dioxide will increase your pH. So if there is a decrease in pH less than 7.3, then there 7.3, so there can be two conditions. One is there can be decrease in bicarbonate or increase in PaCO2. Okay, whether it is because of increase in PaCO2 or it is because of decrease in bicarbonate. If there is increase in pH, then it is because of whether it is increase in bicarbonate or decrease in PaCO2. Okay. Okay. So this condition where there is a decrease in bicarbonate and that's leading to the drop in pH, it called the metabolic acidosis. It's called metabolic acidosis because bicarbonate is more related to the metabolic conditions. If it is because of PCO2, increase in PCO2, it is called the respiratory acidosis. Respiratory acidosis. Similarly, if there is alkalemia because of increase in SCO3, it is the metabolic alkalosis. If there is alkalemia due to decrease in PCO2, it is called the respiratory alkalosis. So, by looking at the first at the pH and then the level of the bicarbonate and PCO2, we can say whether there is metabolic acidosis or respiratory acidosis, whether there is a metabolic alkalosis or respiratory alkalosis. Okay. Now let us look at the example. So if someone has a pH level of 7.3, bicarbonate level of 18 and PCO2 level of 35. So normal bicarbonate level we take is 24 plus minus 4, we usually take. Carbon dioxide we take 40 plus minus 5 pH, you know. So in this condition, what is pH here? 7.3. So if pH is 7.3, there is acidemia or alkalemia? So yes, there is acidemia. So there is acidemia because pH is 7.3. This acidemia is because of what? Bicarbonate or carbon dioxide? For that, then you have to memorize the Anderson and Hasselbalch reaction. So if there is decrease in bicarbonate here, or there is decrease in PCO2 in the at least at lower limit. So this acidemia is because of bicarbonate, not because of this PCO2. Because drop in SCO3 can cause acidemia. So it's because of the drop in SCO3. So this condition is called the metabolic acidosis. This is not because of the carbon dioxide, this is because of the bicarbonate. Okay. So if the direction of the pH and bicarbonate is matching, this occurs in a case of metabolic conditions. If direction of the pH and carbon dioxide is in opposite direction, then it occurs in case of respiratory conditions. Okay, that's how we identify the different metabolic conditions. Okay. So we have validated the AVG and we have identified the different conditions. Then for the compensatory state, for the respiratory conditions like respiratory acidosis, in the respiratory acidosis there is increased level of CO2 and it is mostly because of the hypoventilation of the alveoli. That occurs in case of COPD or different neuromuscular diseases or brainstem lesion. So if there is excessive amount of the CO2 in our body tries to compensate for that by accumulating the bicarbonate in the system, and that can be done by the kidney. So if there is a respiratory problem, then the compensation comes from the kidney. If there is a metabolic problem, then the compensation comes from the respiratory system. So if there is an increase in CO2, then body tries to maintain the pH. Body tries to maintain the pH. If there is increase in CO2, then body tries to increase the level of bicarbonate, so that pH will be normal. This phenomena is called the compensation. Then what is the rate of compensation? It's never complete. For that, we have to know the acute and the chronic compensation. Acute and the chronic compensation. In the acute condition, with every increase in CO2 by 10 mm of Ag, okay, the bicarbonate increases by 1. Bicarbonate increases by 1 milliequivalent. And in case of chronic respiratory conditions, bicarbonate increases by near about 3.5 to 4 milliequivalent as. Okay. For the acute, let's suppose there is increase in carbon dioxide by 10, then bicarbonate should increase by 1. If there is, in case of chronic conditions, if there is increase by 10, then bicarbonate should increase by 3.5. So we have to also comment upon whether there is a compensation in the AVG or not. Okay. So in the acute condition there is increase by 1. So I will give 1 AVG. In case of this AVG, in a patient who have chronic shortness of breath for last 2 years, so probably this condition is a chronic. If someone has pH of 7.34, PCO2 of 60 and bicarbonate level of 28. So here pH is 7.34, so there is acidemia. It's because of increase in PCO2. Okay, because there is increase in PCO2, it's going opposite directions. So that's why it is a respiratory acidosis. Respiratory acidosis. Respiratory acidosis. And if the history is chronic, there is ways to find out whether it is acute or chronic conditions, but let us go with that. Let's suppose if it is a chronic one, so PCO2 changes by, PaCO2 changes by, normal PCO2 is 40 but here is 60, so changes by 60 minus 40 equal to 20 mm of Ag. So if there is a change of PCO2 by 20 mm of Ag, then bicarbonate should change normally by, with every 10 changes, in case of chronic state there should be the change by 4 or 3.5. So every change, if it is changed by the 3.5, then in the 20 it should be like 3.5 divided by 10 into 20. So it became 2 into 7.5. Yes. So your bicarbonate should be 7.5 increased by 7.5, and normal bicarbonate level is 24. So if it is added by 7.5, then it became 31.5. But bicarbonate is 28 only. So that's why there is only partial compensation. There is no complete compensation. So there is only the partial compensation. So you have to write respiratory acidosis with partial metabolic compensation in the AVG reports. Okay. So compensation we can get it. For the respiratory alkalosis, the compensation is like definitely in the respiratory alkalosis. So there will be the drop in PCO2 level. Okay, there drop in PCO2 level, and there will also drop in bicarbonate level in respiratory alkalosis. Okay, if PCO2 level is 10, then bicarbonate will drop by 2. If PCO2 level is 10, drop by 5. This occurs in case of acute compensation, and this occurs in a chronic compensation. So in case of acute compensation, with the trend drop in PCO2, there will drop of bicarbonate by 2, and in case of chronic compensation, if PCO2 drop by 10, then the bicarbonate drop by the 5. Okay, this is how we have to know this value, so that we can comment upon whether there is a no compensation or partial compensation or complete compensation. So for the respiratory acidosis, in the respiratory acidosis what happened? So there is an increase in carbon dioxide. So if there is increase in carbon dioxide, then bicarbonate should increase as a compensation. So in case of acute compensation, with 10 increase of carbon dioxide, bicarbonate increase by 1. In case of chronic compensation, with 10 increase in carbon dioxide, bicarbonate increase by 3.5. Okay, this is for the respiratory acidosis. For the respiratory alkalosis, there is a drop in PaCO2 level. There is drop in carbon dioxide level. With 10 drop in PaCO2 level, there will drop of bicarbonate by 2 in case of acute conditions, and in case of chronic condition, bicarbonate will drop by the 4. This is the normal compensation. And for the metabolic conditions, like metabolic conditions, so metabolic conditions, I will give a very simple formula. Okay, so what is the expected PaCO2 level? So expected PaCO2 level is bicarbonate concentration, okay, plus 15. This is a very simplistic formula. Bicarbonate concentration by this is the expected PaCO2 level in case of metabolic acidosis or metabolic alkalosis. So I will give you example. For like, if someone has a pH of 7.3 and bicarbonate level of 16 and PaCO2 level of 30. So what is this report? So there is drop in pH 7.3. So definitely there is acidemia. So this acidemia is going in direction with the bicarbonate. Okay. So there is fall in bicarbonate. So if this pH occurs because of the fall in bicarbonate, then definitely this is a metabolic acidosis. So there is metabolic acidosis. If there is metabolic acidosis, then what is the respiratory compensation? So what is the expected PaCO2 level here? The expected PaCO2 level is bicarbonate plus 15, right? The bicarbonate 16 plus 15. So it is 31. So near about, okay, near about. So metabolic acidosis. So near about this, there is compensation here. So you can write metabolic acidosis plus compensated respiratory with compensation by respiratory alkalosis. So this is a well compensated ABGs here. So similarly, you can apply the same formula in conditions where there is a metabolic alkalosis. Okay, this is how we check the compensation. So in case of the respiratory condition, in case of respiratory acidosis, in acute condition with 10 increase in PaCO2, there should be increase of bicarbonate by 1. In chronic, there should be increase by 3.5. In case of respiratory alkalosis, bicarbonate should be decreased by 2 in case of acute respiratory alkalosis, and in case of chronic respiratory alkalosis, bicarbonate should decrease by 5. This is the normal compensation. So in case of metabolic conditions like metabolic acidosis and alkalosis, we have to calculate the expected PaCO2 level, which is bicarbonate plus 15. If we add the bicarbonate plus 15, then we can get an idea regarding the expected PaCO2 level, and then we can say whether there is a compensation or not. This is how we can check for the compensation. Then for the anion gap, we usually calculate the anion gap in a patient with metabolic acidosis. So simple is in our blood, so there are major cation and unmeasured cation. We should be equal to the measured anion plus unmeasured anion. So measured cation is like sodium, is one of the important measured cation. Some authors also take the potassium, but as the concentration of potassium is too low, I didn't want to take the potassium. So there is unmeasured anion like phosphate or albumin. These are the unmeasured anions. There are so many anions which we cannot measure, and similarly there are measure anion like we can measure the chloride level, we can measure the bicarbonate level, and there are unmeasured anion the unmeasured cation like calcium and magnesium. These are the unmeasured cation, like this calcium and magnesium. These are the unmeasured cation. Unmeasured anion like phosphate and albumins. These are unmeasured anions. So we need to know, and there are other unmeasured anion and unmeasured cation as well. So anion gap is the like anion gap is if you subtract the measured chloride and bicarbonate from the sodium level, then it will give, like here will be unmeasured anion minus unmeasured cation. So this is the anion gap. So anion gap is nothing, it gives us an idea regarding the different unmeasured anion. If anion gap is more, then we can say that there are so many unmeasured anion in the system. If the anion gap is low, then we can say there are so many unmeasured cation in the system. So anion gap give us an idea regarding the presence of the unmeasured anion in the system, like the acetone. Okay, so we can calculate anion gap by subtracting the chloride level and bicarbonate level from the sodium, and we take the normal anion gap to 10 plus minus 2 is the normal anion gap. Okay, normal anion gap. So normal anion gap is the 10 plus 2. So if someone has the, like I will give you one report. So in case of pH is here is 7.3 and PCO2 is 30, bicarbonate is because of 16, chloride level is 100, and serum sodium is 140. So in this patient we can see that, so there is the pH is drop here. Okay, there is pH is drop. So there is acidemia is here, and this acidemia is because of the drop in CO2 or bicarbonate. So this is plus is the metabolic acidosis here metabolic conditions. So this is metabolic acidosis. So what is the expected PCO2 level? Is the compensation is here, because expected PCO2 is bicarbonate plus 15. The 16 plus 15 is 31. There is near about compensated one. And then we have to also comment upon the anion gap. So anion gap is the serum sodium minus chloride plus bicarbonate. So serum sodium here is 140 minus chloride is 100 plus bicarbonate is 16 here. So 140 minus 116 equals to 24. So it is normal anion gap. It's not a normal anion gap, it's the high anion gap. So if there is a high anion gap, then we can say this is the high anion gap metabolic acidosis with compensation. And there are some of the cause of the high anion gap metabolic acidosis, like in patient with the lactic acidosis, there can be the high anion gap. In case of the CKD, there can be the chronic kidney disease, there can be the high anion gap. In case of the different alcohol intoxication, there can be the high anion gap. In case of diabetes ketoacidosis, there can be the high anion gap. So these are the cause of high anion gap. So high anion gap, you have to know the cause of high anion gap. Okay, so let us revise it again. CKD, lactic acidosis, diabetes ketoacidosis, alcohol intoxications, these are the common cause for the high anion gap metabolic acidosis. So if you see this type of report, then you have to think whether the patient might be suffering from diabetes ketoacidosis or CKD, like that. For that we need to know the history of the patient. There are some conditions where there is a normal anion gap metabolic acidosis. Usually the patient, like where there is a diarrhea, in a patient with diarrhea, where there is a loss of the bicarbonate, and when there is a loss of bicarbonate, then there can be the metabolic acidosis. But in place of the bicarbonate, our body tries to reabsorb the chloride. That's why the anion gap became normal in case of the diarrhea. So in a patient with diarrhea, there can be the normal anion gap. And in case of different renal tubular acidosis state, there can be the normal anion gap metabolic acidosis. So as a MBBS student, thus you have to know some of the cause of high anion gap as well as the normal anion gap metabolic acidosis. Okay. So we have also calculated the anion gap. In anion gap, there are some conditions called high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. For the MBBS student, I won't talk about the delta gap or gap ratio. It will be too complicated for you people. Thus, you calculate the anion gap, and also don't want to talk about the urinary gap for you people. Okay, just you know up to here. So if you are really interested in the ABG, and please write in the comment section so that we can also discuss about the like in case of compensation. I didn't talk about whether how to find out whether it is acute or chronic compensation. I didn't tell you what is the predominant disorder, whether respiratory disorder or the metabolic disorder. These are some ideas, and then I didn't also tell about the delta gap and the urinary gap. We'll discuss these things if you people are really interested in the next lecture. So let us revise it again, and we have to give the final ABG reporting. So before analyzing the ABG, we have to know about the conditions of the patient, what are the symptoms of the patient, what are the examination finding of the patient. Then we have to validate the ABG by applying a simple formula, that is 24 equals to product of hydrogen ion plus bicarbonate divided by partial pressure of carbon dioxide. It should be like 24. And if it is a validated ABG, then we have to see the primary problems. In the primary problems, what we have to see is we have to see for the pH level. Normal pH is 7.35 to 7.45. If it is less than 7.35, then you have to think of acidemia. If it is more than 7.45, you have to think of alkalemia. So if there is acidemia, and if the direction of the pH and the bicarbonate is matches, then that's because of the metabolic conditions. Like in case of if there is a drop in pH and bicarbonate is also dropped, then you have to think of metabolic conditions. If there is a drop in pH but carbon dioxide is increased, then you have to think about respiratory conditions. So you have to memorize these conditions. Then after looking whether there is a respiratory acidosis or respiratory alkalosis or metabolic acidosis or metabolic alkalosis, you have to check for the compensation for the respiratory condition. For the respiratory acidosis, it's 10 for 1 and 10 for 3.5 in acute and chronic respiratory acidosis. In case of respiratory alkalosis, is a 10 drop in PaCO2 by 10 will drop the bicarbonate by 2 in case of acute respiratory alkalosis, and drop in PaCO2 by 10 will drop the bicarbonate by 5 in case of chronic respiratory alkalosis. For looking the compensation in the metabolic state, you have to know how to calculate the expected PaCO2 level is equal to bicarbonate plus 15. You can check whether it has fulfilled the expected PaCO2 level or not. Then after checking the compensation, if it is a metabolic acidosis, then we have to calculate the anion gap. The simple formula of anion gap is sodium minus summation of the chloride and the bicarbonate, and normal anion gap is 10 plus minus 2. There are some conditions which have high anion gap, like in case of CKD or diabetes ketoacidosis, alcohol intoxication. There are some conditions where there is a metabolic acidosis but is a normal anion gap metabolic acidosis, like as in case of diarrhea or renal tubular acidosis. Then you have to write everything. So some of the things I didn't discuss, like as I have already told, and definitely you should also write what is the partial pressure of oxygen, and then we have to also write the A- A gap like that in ABG reports. Thank you so much for your kind attention. If you have any queries regarding this ABG lecture, you can write in the comment section. Thank you.